The Bragg and Steel session highlights innovative work happening across our region and offers practical ideas that we can adapt and implement in our practice. I'm pleased to introduce all 6 of the speakers for the 4 presentations at once in this session. Following the 4 sessions, we will then have a question and answer period. So starting with Ven Rajendran is an advanced practice physiotherapist in the acute stroke and internal medicine unit at Health Science North in Sudbury. As well, he is an assistant professor at the NOSM Northern Ontario School of Medicine. He's also the lead for the Motive project, which you'll hear about in the research and innovation session later. Rebecca Doney is a nurse at Health Science North. She graduated from the Registered Practical Nurse program at Cambrian College in 2019. And while working on the acute stroke and medicine unit, she recognized the opportunity to expand her scope of practice and went on to complete her Bachelor of Science in Nursing, graduating just this past May of 2025. She has since been working as a stroke nurse on the acute stroke unit at HSN, where she continues to focus on delivering high quality, patient centered stroke care. Danielle Hamlin is a district stroke coordinator for the Cochrane District and works out of Timmins and District Hospital. She's been at the Timmins and District Hospital for the past 21 years, and her background includes 18 years in diagnostic imaging, specializing in MRI. Holly Love has been a registered nurse at the hospital in Timmins since 2004. She worked a large portion of her career in the ER and ICU before transferring to the OR, day surgery, and endoscopy unit. In June of 2024, she transitioned into the role of the designated stroke nurse. Kathy Bellefeuille is a physiotherapist with 28 years of experience at Health Science North. Most of her career has been dedicated to neurological rehabilitation, and she currently is the coordinator of the outpatient neurological rehab program at HSN since 2024. Finally, Brooke Davies holds a master's degree in social work and works with the outpatient neuro rehab program. Her practice is grounded in an eclectic, patient centered approach that is responsive to each person's needs, strengths, and goals. Drawing from a range of therapeutic models, including arts based approaches, mindfulness, cognitive behavioral therapy or CBT, acceptance and commitment therapy or ACT, and sand play, she supports patients and care partners in processing loss, building coping strategies, and fostering meaningful adaptation and resilience. Our first speaker, Ven Rajendran, will now start.
Hi, and Rachel, thank you so much for the invitation. Today, I'm going to discuss about our team experience in collecting patient pursued feedback, which is patient experience. That's one. The arrow.
That's, I can do it, I think. Didn't work.
Yeah, thank you. I will also discuss about why we adapted this patient satisfaction survey for our acute stroke patient and how it helped us to identify the area for improvement and what we did to improve the patient experience. I want to disclose the following things. This patient satisfaction survey is a smaller project, which is part of the larger project, which is called the MOTIVE, the Mobile TAA and Stroke with Adaptive Workflow Initiative, currently in place at HSN. This initiative has been funded by the Ontario Ministry of Health, Innovation Models of Care. But to implement patient experience survey, you don't really need any cost. To start with, what is patient experience? It's sum of all interactions. That means when the patient is coming to your facility, as soon as he started having interaction with any staff members, the experience starts, and when it ends, when the patient leaves the hospital, the experience ends, including the transition of care. So that means it is shaped by our organization's culture that influence patient perception across the continuum of care, according to the Beryl Institute. So why we are collecting the patient information at HSN, we do collect patient satisfaction survey for overall medical and surgical patient, but there are no stroke specific satisfaction survey available at HSN. And our manager, Lisa Zeman, and our stroke team member always want to see a higher satisfaction rate. We want to see whether we are delivering enough care to those deserved stroke patients. And we want to understand their perspective, as well as we want to identify the area for or opportunities for improvement. And most importantly, we want to align our stroke care with the Canadian stroke best practice recommendations. So our quality improvement team, including Susan Bursey, who is our regional director, Dr. Singh, who is our stroke neurologist, Lisa Zeman, clinical manager, and Chantal Lidard, our program director, along with myself and frontline staff member. We sat together and we discussed about how we can develop what other item can be included in the patient satisfaction survey. So we came up with the 12 questions. So what we did, after we finalized those 12 questions, we included those in the Microsoft Word forms, which is completely free to implement. And I'm sure actually you might have received this questionnaire from Sue. If not, you can actually get a copy of those. Why we did it? So we collected actually a survey from the first 30 patients to understand our baseline function. This patient satisfaction survey is facilitated by Victor, who is our reactivation worker. So most importantly, actually, this survey just takes less than 1 minute to complete because this is very easy to follow. And we also gave an open-ended question at the end for the patient to write their feedback. So the following tips you can adapt to implement at your site. Either you can simply adapt our questionnaire to start with, or you can revise our survey questions based on your needs. And you can incorporate these questions into the MS form for automation. You don't need it gives a real visual output of how many patients completed the survey and how much percentage of patients are agreed or disagree with the items. And you can, for privacy purpose, you can store your iPad in a secure spot. Oops, okay. So if you're really interested in implementing a patient experience measurement in your hospital or program, either you can contact me or Susan. We are very happy to help you to implement the patient satisfaction survey.
Just following up from Ben there. So I'm Rebecca, as you guys were already made aware. So I'm just going to introduce this new patient-oriented discharge summary that was created here at HSN, just to follow up. So next slide, please. So how was this PODS created? So after conducting a patient satisfaction survey, like Ben had already mentioned earlier, we noticed there was quite the gap in the discharge planning and how they felt comfortable when they left here. They didn't receive enough information upon discharge. Next slide, please. So basically, PODS is not new to Ontario. There's 27 other hospitals that are across Ontario that have implemented PODS. Sudbury's not one of them, so we're hoping to be maybe number 28. Just to mention what PODS was, PODS has been designed by the stroke neurologists, the patients, feedback from the satisfaction surveys, PT, OT, dietitians, the stroke nurses, all had a part in creating this PODS here for HSN. Next slide, please. So this is just an image of the ward clerk pretending to be the patient as an actress, but this is basically what a day would look like with the teachings. So PODS is a very easy to understand paper. It's large fonts, we use pictures, very easy language to understand, so we get rid of that medical jargon, which also aids in the memory recall with this paper. Being able to go back and refer to the information that's on this paper well after discharge. PODS is completed with the patient or family member at side. And it's very actionable, like I was saying, focused on useful information for the patients and their family. It includes 5 areas for sure, where there's the medication, any new medications we start them on, like aspirin, Plavix, a statin, is listed there for them with their dosage, so that it's quick reference later on. Changes to daily activities, like the risk factors, are all listed individual to that patient. Follow-up appointments in the stroke prevention clinic and or ONR, which is the outpatient neurological rehab, IRU. All of those areas are all available to be clicked off. Checkbox, very easy. Resources for the families as well. So we like to add in the FAST symbol for any symptoms to watch out for after discharge as well. So all 5 of those areas have been touched for our pods. Next slide, please. This is an example. This is what our pods looks like today. As you see, we have some color, a lot of imaging, as large font as we can fit in there, and some bolded areas that pop out to the patient so that they can really see what they need to look at. We have driving restrictions, like I mentioned, just basically everything that we can think of at this moment. And that basically concludes what I have for pods, or what we have created as a team here at HSN, just so that the patients feel a little bit more at ease when they're leaving here. I've had great feedback from the patients, nothing negative, always positive from, this is great, I can bring to my doctor's office for reference. I've heard comments of, thank goodness I can actually look back at this. I never remember what you guys tell me when I'm out of here. So it's been great, very positive and great feedback. And that would, next slide, please. And that concludes everything. So thank you very much for listening.
Good afternoon and welcome to our Bragg and Steele session, Integration of Stroke Community Navigation at Timmins and District Hospital. So we just want to start by saying the post-stroke transitional care program has worked effectively at the Timmins and District Hospital with a collaborative approach to provide client-focused stroke care. This partnership supports seamless coordination between hospital and community-based services, ensuring clients receive timely and appropriate support following discharge. This collaboration approach has also helped reduce stress for stroke patients by improving communication, coordination, and clarity during a challenging transition period. The March of Dimes Stroke Community Navigator connects directly with the Timmins and District Hospital Stroke Unit to coordinate referrals. With weekly hospital visits and regular phone calls, our Community Stroke Navigator connects with the stroke nurse. Once a referral is received, Stroke Community Navigators book an intake appointment with the client and places them on a waitlist for physiotherapy and cognitive services as needed. Once the referral is received, the Stroke Community Navigator begins supporting clients with system navigation, including finding physicians, booking medical appointments, and arranging transportation. In addition, our navigator provides education and best practice measures at intake, helping clients understand stroke recovery and available support. Clients have frequently expressed relief and reassurance in speaking with someone who can explain what to expect during stroke recovery and guide them through the process. Working collaboratively has been highly beneficial for both agencies, and most importantly, our clients. The coordinated approach reduces service gaps, eases patient stress, supports smoother transition from hospital to community care, and ensures clients receive the right support at the right time. We want to thank Amanda Sharchaw for her input on this presentation. She is no longer in the role of Stroke Community Navigator, but we look forward to working with the new navigator here at the Timmins and District Hospital.
And thank you to everybody for having us today. So we're from the outpatient program here at HSN from Outpatient Neuro Rehab, and we're going to share with you today the how and the why we meet patients in acute care prior to hospital discharge to create a smooth transition to our program, our neuro program or community stroke rehab program. And this process is something that we call our warm handover. Next slide, please.
So the highlights that we kind of want to hit with you today are: what was our challenge? How did we try to solve it? What barriers did we encounter? What are our outcomes? What do the patients think? And what are the key takeaways?
Next slide, please. Ontario Health's community stroke rehab model of care emphasizes the importance of timely and equitable access to outpatient stroke services for all. We recognized in our own patients the challenge they faced in moving from a supported inpatient environment to the unknowns of community stroke rehab. The patients were wondering, what happens now? When will the outpatient clinic call me? Can I reach them? How often will I be attending? What's my schedule? Can my family be involved? How can I get there if I can't drive anymore? Can I be seen in my home? So we wanted to ease the fear and anxiety involved in this adjustment for patients and the caregivers. So we set out to create a model to do warm handovers in hospital to smooth this transition and put a face to the program and close the gap. Next slide. More specifically, to achieve this, we created team-wide competencies. This ensured that all of our team members are skilled in conducting these warm handovers, including our rehabilitation assistants. We do this by creating shared understanding of the benefits and importance of early patient engagement while keeping a patient-centered approach. We also created a unified approach by developing rapport with the inpatient teams to ensure continuity of care. Next slide.
Okay, so how do we actually do it? So before we do a warm handover, we receive the referral and we establish whether or not the patient is eligible. Then we look at what team member might be available to actually go and do the warm handover. We call over to the floor to see if the patient is available when we're able to get over there. We consult with the schedule and the medical secretary to see when we might be able to provide intake opportunities. And then when we're actually there, we meet with the patient and the caregiver if they're present. We introduce ourselves and we briefly explain the ONR program. We establish the patient's interest and their consent to book an intake. And then we establish the best location for that intake. So that might be the patient's home, or it might be our clinic, could be OTN, or even over the telephone. We provide them with a brochure with the appointment date, our clinic location, and any contact information. And then we identify any barriers. So they may have barriers to transportation, that's a big one, or communication that we might be able to support. And then we answer any questions that they have. Next slide, please. Okay, so what barriers did we encounter throughout this process? So patient schedules, sometimes patients are gone for last minute diagnostic testing or rehab appointments. Sometimes they're out with family or they have a doctor's appointment. Another barrier for us is that we are located off-site from the main site of the hospital. So that physical barrier is sometimes a little bit challenging, and it also causes us to have to plan a little bit more, which can be difficult with staffing availability at times. And then finally, it's the quick turnaround, which can be a barrier. So when there's limited time between the date that we actually receive the referral and the date of the patient's discharge, we struggle to actually get to meet the patient.
So this quick turnaround time truly does impact our ability to conduct the proper warm handovers. On this graph, you'll notice we were able to conduct warm handovers with 74.3% of patients being discharged from the inpatient rehab unit, in compared to only 22.2% of those being discharged from acute. As the explanation for this discrepancy, you can notice that we were given 2.3 days notice between the time the referral was received by our clinic and the inpatient discharge, compared to 0.6 days notice from acute care. Next slide, please. On this graph, these were our outcomes. So on this graph, you can notice our wait times from inpatient discharge to outpatient ONR intake decreased by approximately 1 day, which is essentially a decrease of 17 to 25%. And more subjectively, we notice reported improvements in patients and caregiver experience, along with the reduced transition anxiety. Next slide.
So I had the opportunity to speak with a patient the other day, as well as a different patient's caregiver, about what their experience with the warm handover process was like. So these are just little snippets from some quotes that they gave me, but I'll let you read those on your own. But basically, to kind of summarize, we really reduced the uncertainties and the unknown next steps for patients and their families, which we were happy to hear about. We addressed some transportation concerns. We were a point of contact for that family and provided some familiarity. We put them more at ease about being discharged. And finally, there was some accountability to follow through with outpatient rehab.
Next slide.
So we want to kind of give you some highlights of things that you can do, whether you're working in inpatient or outpatient programs, to support warm handovers.
So in inpatient units, initiating early referrals to outpatient rehab will help us support earlier intake dates, establishing direct contact with the outpatient rehab team to confirm referral appropriateness, integrated discussions between outpatients, and getting the referral timing discussed at your bullet rounds, and maybe encouraging patients to ask questions to the outpatient team so we can support that seamless transition. And outpatient programs, we would recommend establishing a point of contact with the inpatient units, building team-wide competencies and shared team understanding of the value of this initiative, adopting that unified patient-centered approach across the whole continuum, and then implementing a dedicated triage team that has a clear understanding of clinic capacity. Next slide. So that's the end of us, and that's how you can reach us. Thank you.
Thank you.
Very good. Thank you very much, ladies. So we have 5 minutes left to ask questions about the 4 presentations. So the patient experience measure, the pods, the Stroke Community Navigator, and the warm handover. I'm going to start with the chat. I did put the patient survey from HSN into the chat. So if people want a copy of that, they can click on that and get a copy. There's questions around the pods. Are the pods completed in acute care uploaded to Meditech for receiving teams to view? Rebecca?
Yeah, go ahead. Actually, it has not been uploaded to our Meditech Expanse yet. It's still hard copy with paper. We've been using a sticker to identify which patient. I make a copy. The patient has the original, and a copy goes down to the clinic with them at this time until we can get it approved in an Expanse or Meditech.
So there is a plan that we would try and get it into Meditech at some point. Excellent. Thank you. Second question, Rebecca. They love this and will definitely be stealing this idea. Just curious if it's scanned into Meditech, and so not yet, Rachel, but hopefully that's coming. And I wondered if we had a copy of the pods, Rebecca, and we could put it into the chat. Is that possible?
Yeah, definitely.
Okay, so if you send me a copy of it, an electronic copy, then I can send it out to the registrants after.
Definitely.
Thank you very much. Next comment is around the Community Navigator. So for the time being, calls for the Timmins Stroke Community Navigator can be directed to the Stroke Navigator in Sault Ste. Marie at extension 3019. As Danielle mentioned, our longtime navigator in Timmins has moved on, and so we haven't quite finished put the role in yet, put somebody in that role in yet, but I'm hoping that it's coming. And so once that happens, we will certainly be announcing it so everyone is aware of who the navigator will be there. We are going to share a blank pods form, so thank you very much for that question, Lisa. Susan, would you like to ask something before I finish the questions in the chat?
Yeah, I was going to type it in, but haven't had a chance. So here's
That's okay.
It is live. Okay, so we talked a little bit earlier that there's been a few iterations of the pod so far. So I'm curious if there's something else you want to add to it. I know we talked about translating it. We talked about, a few other tweaks, but is there anything else that you want to add to it that would help with patients?
Yes, actually. One part that I think would add, I get a lot of phone calls after discharge asking exactly where their stroke was and what type of stroke. So I'm wondering if maybe an image of a brain can be put at the top and we can circle left or right or which lobe or something like that, just to give them a reminder of where they had that stroke.
Excellent. Excellent idea. I know our manager, Lisa, said the pods is still work in progress, and once we have more data and come to the final version, we can work on uploading it into Meditech. Thank you for that, Lisa. Question from Brad. I'm curious to whether these are dedicated social workers for the CSR program who are assisting with these warm handovers. Social worker in Timmins for CSR would be ideal, not just to assist the handovers, but in general for the community stroke rehab program. So can you talk a little bit about your staff that are in that program?
Yeah, so I am a social worker, but anybody on our team is able to do a warm handover. So it could be the rec therapist, it could be an assistant, it could be a physio, it could really be anybody on our team who's available. We're all trained on how to do it.
Mm-hmm. Thank you for that question, Brad. If you just want to put up the evaluation, and put the evaluation link in the chat. Please evaluate this Bragg and Steel. It was our first time doing it. It's not a really smooth transition to go from speaker to speaker, but we wanted people to be able to show some excellent things that are happening in programs across the Northeast, and then maybe others in our area would steal those ideas and get them happening in their hospitals or their areas. So thank you for joining us for the Bragg and Steel today.